Hello everyone. In this part of the implant protective occlusion series, let's talk about cantilevers and implant protective occlusion. All of us know that cantilevers are force magnifiers for implant and bone system. Now there can be three types of cantilevers that an implant or a group of implants can support. They can be vertical cantilevers or they can be cantilevers in the horizontal plane. In the horizontal plane, the cantilevers can be in the anteroposterior direction or the mesiodistal direction and the buccolingual direction as well. Let us first talk about cantilevers in the vertical plane. Whenever there is a crown height space of more than 8 to 12 mm, then it acts as a vertical cantilever for the implant in case the occlusal loading is not along the long axis of the crown or the long axis of the implant. Understand that if an implant is loaded along its long axis, then the crown height does not act as a vertical cantilever. It acts as a vertical cantilever only when angled force or a cantilevered force or a lateral load is applied to this crown over this implant body. The best way to manage a large crown height space for a single implant or a group of implants is by increasing the height of the bone by vertical bone augmentation. If that is not possible, then the other method to manage crown height space is to place the implants perpendicular to the curve of Spee or curve of Wilson or the occlusal plane so that the crown can be loaded along the long axis of the implant. It is also important to ensure that these crowns do not have high cusp angles and that the opposite cusp lands directly over the central fossa of the crowns over these implants so that the occlusal load can be directed along the long axis of both the implant crown as well as the implant. Whenever you have a crown height space of more than 12 mm in a group of implants, the best method to reduce the cantilevered force is to increase the distance between the splinted implants and use a removable prosthesis over it. Now let's talk about cantilevers in the horizontal plane. In the horizontal plane, the cantilevers can be in anteroposterior direction, like molars cantilevered from premolars or molars cantilevered from molars or laterals cantilevered from canine. The larger the length of these cantilevers, the greater the loading to the implant and the bone crest. The more posterior the location of these cantilevers, the greater the loading to the implant system. The lesser the distance between the splinted implants, the more the loading over the cantilever portion and resultant overloading over the supporting implant systems. The best way to manage overloading over horizontal cantilevers is to not have cantilevers at all. But if that is unavoidable, the most important thing to consider are the force factors of the patient. If the patient is a parafunctioning patient, then cantilevers should be avoided altogether. If there are no parafunctions, if the patient's force factors are low, for example, a female old age patient, if the bone density is good, and if you can place sufficient number of wide and long implants in this patient, then you can have cantilever of the length 2.5 times the AP spread. If you do not understand what is AP spread, watch my video on key implant positions that explains it pretty well. In case you have implants that are splinted in the same plane, then the only cantilever length you can afford is equal to the distance between the centers of the splinted implants. The number, the size, that is the length and the width of the implants, and the distance between them should be increased. The crowns in the cantilevered area should be out of contact by at least 8 to 12 microns as compared to the crowns that are placed directly over implants. There should be no lateral loading over the crowns in the cantilevered area in the posteriors. That is, they should be completely disoccluded on any of the excursions. Now let's talk about cantilevers in the horizontal plane but in the buccolingual direction. A large crown over an implant that overhangs the implant body is a horizontal cantilever as well. It is called as offset loading. The overhanging portion of the crown beyond the implant diameter is called as an offset. The loading over any of the offset areas, the loading over offset areas is a cantilever load to the implant crown. To avoid any offset loading over an implant, the occlusal table of posterior implant crowns are made narrow. The occlusal loading is directed along the long axis of the implant over its center itself. No contact over buccal cusps is required in the mandibular crowns and no contact over the palatal cusp is required in the maxillary crowns, unlike the natural teeth. All these contacts, along with the mesial marginal ridge or distal marginal ridge contacts, act as offset loads over implant crowns. A narrower occlusal table also increases the efficiency of mastication. So I hope you understood that it is best to avoid vertical or horizontal cantilevers over implant systems. But whenever unavoidable, it is always advisable to reduce the overloading over the implant and the bone system by the measures that I have already illustrated in this video. Hope it helped.